Unhappy patients. We've all dealt with them, we've all been frustrated by them, and we've all learned valuable lessons from managing these patients. I'm Ben LaHood from the Queen Elizabeth Hospital and Ashford Advanced Eye Care, Adelaide, Australia. And my task for today is to moderate a lively discussion with a few of my colleagues on this very topic. Welcome to a special episode of CRST, the podcast. Joining me today are Jorge Alió from Visum Instituto Oftalmológico de Alicante in Spain, Glenn Carp from the London Vision Clinic, Radhika Rampat from Queen Victoria Hospital, East Grinstead in the UK. Before we get started discussing best practices in patient counselling, let's go around the table and share how we'd manage a few cases of patients who are unhappy after cataract and refractive surgery. My feeling with nearly all disappointing outcomes is that there's just a simple mismatch between expectations and outcome. It is very rare these days to have a true refractive surprise, but it does happen. So my first case I would like to discuss is a patient who came to see me very unhappy with monovision they'd been given elsewhere. Elsewhere, of course, I didn't do it, of course. They were 51 years old. Previously, they were a moderately high myope. They underwent LASIK with one eye set for distance and the other set for -2 myopia. Now, it's a reasonable thing to do. The patient, though, was really missing their intermediate vision for the computer and lots of daily tasks. I'd be really interested to know how you'd manage this patient. She doesn't know how lucky she is to have 3 world experts comment on her case. I'm going to pretend that this was all my thoughts. But Radhika, can I start with your opinion? What would you do, and how would you have avoided this in the first place?
As we know, patient counselling is extremely important. And if the patient had perhaps done a monovision test with a contact lens prior to that and seen if there was a time for neuroadaptation, that would have been quite helpful as a preoperative plan as well as the counselling.
And now that we're in this situation, what do you think you'd do? I know I'm putting you on the spot here. I should have given you this earlier, but what would you do?
I think that the question really is, how long has it been since the patient has had the procedure? Because if it's been a couple of weeks, I would tend to say wait and see, although not every patient would be happy with that answer. I might go ahead to Mr. Carp and ask for their advice instead. But that would be my first instinct. But if they've been in that position for much longer, then I'd be thinking about, laser enhancement of their situation to perhaps change it, using whether you're going to use asphericity or spherical aberration, whatever it is, within your laser correction to make those changes.
Thanks very much. Now, Glenn, would you have done anything differently? Do you actually do standard monovision LASIK anymore, or have you left that realm and gone fully into Presbyond?
Yeah, so we've been performing Presbyond for the last 16 years. We don't do monovision anymore. We don't prescribe to monovision. I think that the key problem with monovision is that it's only well tolerated by 60% of people, and that leaves a large percentage of people feeling a little off balance. One of the interesting points you made about this particular patient was that it was a high myope, moderate to high myope. So the truth is that when we treat moderate to high myopia, the amount of spherical aberration we do induce just from the treatment, even using an aspheric profile, modern aspheric profile, should leave the patient with some reasonable amount of spherical aberration for increased depth of field. So you're probably not even doing monovision, you're doing a variant of Presbyond. It's just not very well controlled. And remember, inducing spherical aberration to anywhere between 0.3 and 0.6 microns, 0.5 is the optimal, will leave patients with increased depth of field at the level of their cornea. In this patient, though, the reason the patient's probably unhappy is because the amount of residual myopia present is a little bit too much for a 51-year-old. So -2 wouldn't be an optimal target to aim for. We would aim for a target of about -1.5 anisometropia between the two eyes. So essentially what we're saying is that you leave spherical aberration in the system at a level which gives depth of field, but not at a level which is toxic, which reduces contrast and gives night vision problems. But at the same time, because we can't increase the amount of zoom sufficiently without leaving them toxic, we have to borrow from a little bit of microanisometropia. And -2 between the two eyes, especially for a 51-year-old, is just too much. So the answer is, what you would do for the patient is you would simulate for them through a phoropter or a contact lens, because they've got the spherical aberration in the cornea already, reducing the amount of anisometropia, and you titrate it down. If they become comfortable with a half adapter reduction, leaving them a 1.5 difference between the eyes, then you could simply do a standard aspheric enhancement just to move and shift the refraction to a more comfortable level. At the same time, if the 150 was still too much in a 51-year-old, you could even consider reducing it to a -1 difference between the eyes, because the spherical aberration will make it as if it's a -1.5 when they're at -1 with the increased depth of field.
Ah, that's really interesting. With just on a personal note, can you lift a flap and give a presbyond like treatment when someone's already had a treatment done before?
Sure you can, but the point being is that most cases for enhancements, you don't need to reuse a presbyond profile. Generally speaking, the amount of spherical aberration present is going to be good. So it's really more of a refractive treatment, just using an aspheric profile, just to shift the refraction. If they don't have enough spherical aberration, you can obviously use a presbyond profile, sure.
Oh, that's really interesting. Thank you. And Prof. Alió, would you do anything different in this scenario? How would you think about avoiding that? I agree with Radhika that the answer really would be a contact lens trial beforehand, but do you have any other methods before treatment that you think about with monovision?
No, in this case, my point is that -2, in my opinion, is a too much aggressive near vision target, Usually when I do a monovision, I leave, especially in people that have been previously myope, a -0.5 in the dominant and 1.5 in the non-dominant. In doing that, you get very good intermediate, very acceptable near, and somehow that not optimal for far, but myopes usually are not unhappy with this because the far vision is usually moderate to bad, So with this target, usually the patients are happy. I agree totally with Dr. Carp about the use of peripheral profiles that induce spherical aberration in a calculated way. And we use, in these cases, definitely if the indication fits well with the patient, the PRESBYMAX. So PRESBYMAX from Sweden is the one that we use, and it's a bispheric profile, and it's pupil dependent. So we look at the pupil photopics should be 3.5 about or less. And with this micro monovision with -0.5 dominant, -1.5 in the non-dominant, I think that I never have an unhappy patient for intermediate. I might have an unhappy or relatively unhappy for near, because some of these myopes are accustomed to use activities that are near vision activities of highly relevant discrimination. And in these cases, to read very small characters, they will need glasses. And this should be openly discussed with the patient. I don't trust, believe me, and I know this is controversial, in contact lens trial, because contact lens trial is unreliable. You don't have the patient that much time in the office to guarantee neuroadaptation, and the daily life activities of the patient are not in your office at all. So the patient might feel good in your office and not happy at home, and conversely. So what I do is just a normal trial, not to be convinced myself about the effectiveness, but the patient to understand what is monovision, what means one vision is slightly better for near, while the other is slightly better for far. And with PRESBYMAX, which is a combination of micromonovision in the hybrid form and the spherical aberration change in the periphery, the patients are definitely better than with the trial. So this is my point. In this case, for being practical, I would make a trial with a plus 0.5 in the emmetropic eye, which is the dominant. I would make a minus 1.5 correction in the non-dominant. I would test the patient, listen, be for a while, use your laptop, let me know if you feel better. Probably the patient will be better, and then you need to treat both eyes, inducing that this is small myopia in the dominant and decrease the -2, which is too much non-dominant. This is a piece of cake, and if the patient is happy, that's it, and this is the approach in this very case. Yeah.
That's really interesting. Thank you. I usually do a contact lens trial for about a week. I don't do it just in the office. So I get around that problem that way, but it is time consuming, and I probably lose some patients that way. the one other question I'd like to ask you, Prof, would be, do you always aim the dominant eye minus 0.5, or is that just in high myopes?
High myopes, because in the just hemetropic, I leave hemetropic, but it's not my choice for hemetropic monovision. Let me tell you that I use in hyperops and myopes, both, from up to -4 and to +4. Beyond that, I prefer other methods, because the monovision in these patients, especially very high myopes, is tricky, and the lack of contrast sensitivity, which is usually not that good in very high myope, is not optimal, for monovision.
I understand. Now, I don't want to give the impression that I have a lot of unhappy patients, but I have one more I'd like to ask you about. I have a patient that was undergoing cataract surgery with plans for implantation of a trifocal IOL. They were very keen to be completely glasses independent, but it appears that during their surgery, they had a posterior capsule tear and they had a monofocal lens put in the sulcus. So very disappointed with their outcome. I have inherited them, and I've been asked, what can I do for them to make them glasses independent? They really had their heart set on good distance, intermediate, and near vision. So one eye is pseudophakic, the other eye is still phakic. Glenn, can I start with you this time?
Sure.
I feel like your answer to this one again might be Presbyon, but I would be interested to know how you deal with this, because as someone that doesn't really do multifocal corneas, or doesn't aim to, I feel as though I'm probably stuck with saying this eye is what it is, and the other eye we might try for multifocality. So I'd really like to know what you'd do.
So, I mean, certainly, yeah, we would still consider this patient an excellent candidate for Presbyon. The fact that you've used a monofocal lens keeps them totally in the game for Presbyon. In fact, the opposite is the case. You shouldn't perform a Presbyon treatment in somebody who has had a previous multifocal lens placed inside the eye, because with the increased depth of field, it can bring out the multiple peaks of focal points within the lens, and it causes a lot more confusion and a lot less absorption of the diffraction of the light that's coming in that shouldn't be hitting certain targets in the retina. So the fact that this patient's had a good quality monovision optic placed inside the eye makes them an ideal candidate for Presbyon. We would simulate a 1.5 diopter anisometropia target. You've got to understand as well that, just like we discussed with the contact lens trial, when you're doing a contact lens trial, you're simulating monovision. It's pure monovision. They don't get the depth of field, which they will get from the spherical aberration adjustment. So by just measuring the whole eye spherical aberration after the IOL has been placed inside the eye, the algorithm will very comfortably shift the spherical aberration. It'll increase it accordingly or decrease it if necessary to leave them with the optimal amount of depth of field. And this will be at the level of the cornea. And just to finish off, it's the same approach we use for our current patients when we do Presbyon in the future when they develop cataracts. We simply place in a good quality monofocal IOL. And again, if we need to shift the spherical aberration, we can do that with spherical aberration that comes with the lens. So we can choose our lens accordingly to move the spherical aberration a little bit if it's required. Yeah.
I love how calm and confident you are of these problems. It makes me feel a lot better, because you've obviously seen this before and have dealt with it and confident in the outcomes. So that's really nice. Radhika, would you do anything differently for this patient?
So I think one thing I'd like to know at this point in time about the patient would be, is this their dominant or non-dominant eye? I think that that's where we should begin. And then we want to know, does the patient want to do anything with that eye? Do they want further surgery on that eye, or have they come to you actually to go away from that other surgeon and go for something in the other eye? Now, it's perfectly good to mix and match a multifocal IOL in the other eye with a monofocal IOL on this eye. A lot of, brilliant surgeons, I mean, even including, say, Damon Gattinelli, when we came up with this at a table discussion, was actually maybe I would do one monofocal C and then go for another his own trifocal in the other eye.
That's probably more what I was thinking, to be honest. Yeah.
But at the same time, as Glenn mentioned, we have a lot of options with multifocality within that cornea still. Now you mentioned Presbyon, we mentioned Presby Max, and don't forget we've also got Presby LASIK. Changing the corneal asphericity, as I've done some work with Damien Gatinel on that. So we do have a lot of options, and I think we shouldn't forget that the patient has their own natural high order aberrations, and then also that the monofocal lens itself is not without its own higher order aberrations. And then it would be really great now to plan, with all these options that we have, the perfect multifocality for that patient.
Thank you. And Prof. Alió, we've got probably one vote in each camp so far. We've got the laser option, we've got a lens option. Which way would you go?
Well, it depends on the condition of the eye that suffered the complication, because the eye, I understand, is hemetropic, right?
That's correct.
Okay, and the other eye is with a cataract or has a dysfunctional lens, probably, right? Okay.
Yes.
With a dysfunctional lens, the problem is that you have not a good candidate for cornea surgery, but rather for lens surgery. So the indication was appropriate, and you have two options. One is what Glenn mentioned, just to decide cornea surgery, having in the other eye just the induction of a slight monovision, for instance 1.5 negative, with the use of a negative asphericity lens, and then to target with Presbyon to refine the vision in both eyes with some extraspherical aberration according to the final total aberration. This is one approach that it follows the cornea indication, but my approach would be different. I would finish with the eye that you suffer the complication, and I would use a sulcus flex lens. So I would explant the lens because obviously when you have the complication, you don't have a plan to operate the room. You have just the sulcus lens that things is always calculated and you can use it, but you don't have this possibility of a plan B with a sulcus multifocal lens. In my hands, the sulcus flex has worked properly. So to explant this lens using the incision in the positive meridian in case that you have any astigmatism can open the field of having again the patient recover from multifocality. And if successful, that should be successful, if no macular edema happens, obviously, then the second eye will be for a multifocal lens of the same type. That means the Reiner, which is a refractive lens, the sulcus flex, is a very good lens. The cases that have like this have been always successful, and believe me, I think that this is the best option because cornea surgery would mean for this patient to have intraocular surgery in this eye, and on top of that to have Presbyon, which is a duplication in expenses, double time, and finally the idea was to create multifocality with the lens. So I think kind of different because in a patient that has been already the subject of an indication and explanation of multifocal lens is not that psychologically successful many times. The patients are simply waiting for a better option,
Yeah, I love that for anyone listening, we've got 3 world experts in refractive surgery and we've given them 3 completely different options. So it just shows you that there are many ways to skin a cat and there's no absolutely correct answer, but thank you all very much. I'll take that on board and I'll have a good think before I talk to this patient again. Now, I'd also like to talk to you all about patient counseling. We're doing more and more with the lights that we have available. We're using multifocal lenses, we're playing with spherical aberration, and it seems as though any patient that walks in the door, we can pretty much offer them great vision and whatever they want. But I often tell patients that no matter what we do, there's probably some kind of trade-off. You can't really have the vision you had when you were a teenager. And the question really is, how do you establish healthy expectations with your patients? Radhika, do you have any tips for not over-promising?
Yeah, sure. So actually, I did a huge review with Damien in ophthalmology on multifocal IOLs just at the end of last year. And just from working on that piece of, that project really, over 6 months, I really gained a lot of insight into what's happening across the globe. I think what definitely for patients, it's all about, underselling and overachieving or overperforming. And there's two ways to look at it. One thing is that I create a lot of tables and figures in that paper showing, what's the preoperative kind of procedure for these patients. Certain tips and tricks that might have been missed in that long paper would be things like if a patient has a dense amblyopia or has any sort of strabismus, that they must go and see an orthoptist before, or things like what is their baseline high order aberration. And I do find that every paper pretty much said that if a patient has a cataract already there, they already have some starburst, they already have some halos that they've neuroadapted to, they're more likely to be happy with their lens surgery with a multifocal than a patient who's having a clear lens extraction. If you do go ahead and offer a clear lens extraction, you better understand the patient's requirements to a very high degree. I know that means a little bit more chair time. Other ways going around that would be to use, products available on the market which can actually collect that data. Like for example, Arthur Cummings with Vivio, or I forget the other lady's name, but she's doing SimViz as well. And it's amazing what is now becoming available for us to actually give patients an idea of what they might be able to expect. And finally, I think what I would say is that there's a lot of discussion at the moment internationally about how to categorize lenses. And it's not just the surgeons, it's the patients, and it's also, the FDA. They all are struggling with this right now. So that's another very interesting part of that discussion with patients as well.
And so, Radhika, do you, keeping that in mind about the difference of coping with people that have cataracts or clear lens, do you offer them different options, or is it just that your counseling is a little bit more in depth and you'll feel them out a bit more?
So personally, I'm just starting out as a junior consultant. So, I'm at the beginning of it, but, I think that the in-depth information that I have learned from doing these papers and work, and also actually sitting in, NHS or National Health Service clinics where we see patients who are unhappy and have been referred to, my colleague, Professor Gartry, for example. He gets a lot of unhappy patients, and he's obviously an expert in laser surgery and correction, and also multifocal IOLs. And it's amazing to see these patients in clinic come in, and actually a lot of their problem is not having understood preoperatively what they were going to get, what they're signing up for. So I don't offer clear lens extraction as yet, but definitely what I would say is that I personally, as I take this on, would prefer to almost have a cutoff point for, and have a patient only with cataracts initially, and performing lens extraction and multifocal lenses for them. I think as you get more confident with your own data, you can then start to consider clear lens extraction and things like that. And almost having, even if a patient has a cataract, almost having a cutoff for a, scatter index to say, actually, I don't want to perform this until you are at this level. And of course, having that conversation with the patient and coming to a decision together.
Yeah, that's really good advice for anyone starting off, because, using multifocal lenses can be a bit daunting. Prof. Alió, do you offer all possibilities to all patients, or do you hold some things back when you're counseling patients about their cataract options?
I think that the indication should be customized to many factors. One is the age of the patient. Definitely. Second, the dedication of the patient. Third, the hobbies. And finally, the personality. You have to take all this cocktail of together, in order to bring what is adequate for the patient. I try to identify in my discussion with the patient all these issues, the personality, how tolerant the patient can be to things that could happen, including the adaptation. How is the patient in terms of dedications? Out from labor dedication usually today involves a lot of computers. And finally, which are the real needs of the patient according to age. I usually indicate cornea surgery when I have the patient below the age of 55, especially MIBS, and everything which is beyond 55, I prefer to use intraocular lens surgery. So with this in mind, I have two categories. and a lot of flexibility, because doesn't mean that in a patient that has a +7, I don't indicate refractive dist exchange and the ISO 45. This is number one. Two is the type of procedure. Type of procedure means either you are going to get a multifocal cornea, which is a kind of tricky, and the patient should understand what is going to be the behavior, what is going to be the long-term evolution, because this is not going to be forever, and what you can guarantee for the patient. And we need from that moment to state clearly that we're not God, we're making estimations based on experience and data. Very important to have data. And I expose my patients to my data, because this is relevant. They know that some patients can be not happy because the outcome could be not sufficient, and then this can exist, even that is not that frequent if you do things properly and usually the patient properly as well. And about lenses, I use a variety of lenses. I'm not attached to only one lens. Some lenses are very good for near and just adequate for far, while others are much better for far and less good for near. Some lenses are bad for far and for near. I'm very disappointed by the EDOF lenses, most of them, not all, but the EDOF lenses are not the beauty that has been formerly expected. Even the new generations are totally different. And I try to identify the need of the patient, the style of life, the personality, etc., in order to mix this in a way that I made the indication that is adequate for the patient. I have to tell you that we have all of us unhappy patients, but we have two categories: those that are disappointed and those that are unhappy and aggressive. We are guilty because of the first. If the patient is disappointed, it's because we have not informed the patient properly and we have not dedicated the time to the patient in an effective way. When the second are usually complications, photic phenomena that should be avoided. Neuroadaptation happens to be tricky, when neuroadaptation failures happen. And, I found that a way to treat the unhappy patient because of neuroadaptation problems by exchange by another multifocal. This is coming for publication now, but it's interesting to know that if you have a diffractive unhappy patient, you can explant and substitute by a refractive lens, multifocal, and the patient can become happy. And so that means that we don't understand completely what is going to be the outcome, but in most of the cases it's predictable. Definitely the indication, the chair time, the adequate information that you have, and to know your data and what is the lens that you want to implant, what is the offer that you know that you can really offer to the patient is top quality information that you have to use for the purpose of success, which is finally the success of the patient.
That's really good. So yeah, it's a combination of you having to be a bit of a psychologist, but also showing them your evidence and your results.
Yeah, and this in 10 minutes, Ben, this is...
Yeah.
Okay, so you have to be very effective. You have 10 minutes for that.
Yeah, that's fast.
Should understand you. That's
I
right.
can't do it that fast. Now, Glenn, you've got the wonderful setup of mainly concentrating on laser surgery. Now, do you still have long appointments? Just, you've got fewer options to discuss perhaps, but I imagine that you still take a lot of time to discuss with the patients the expectations. Do you approach it any differently?
First of all, I have all the options available to me. In our practice, we perform, cataract surgery. We have the option of using any lens we choose. We don't really use multifocal lenses. It's not our preferred methodology of correcting even cataract surgery. And we have ICLs, we have laser technology as well. I think for us, the big concept that we're trying to approach our patients from is in terms of both amount of vision, how far they can read down the charts, and the range, distance and near, as well as the quality of the vision. So for us, any patient, regardless of age, if they have good quality of vision, they've got good contrast, their OSI is in the normal range on the HD analyzer, we perform corneal laser correction and we use Presbyon. We explain to the patients that, yeah, these treatments do need enhancements as the years go by. And in the future, when you do develop a visually significant quality of vision cataract, then of course you can have that replaced simply with a monofocal lens. It can be done at any cataract surgeon or through us as well. And I think the point as well is also about the risk side of things. We know that the risks of intraocular surgery are different to corneal laser surgery as well. So even from my own perspective, the magical age group of the 45 to 65-year-old patients, where you can perform a corneal treatment and you may end up doing 2 enhancements over that 20-year period to keep them in functional vision, but also with good quality of vision. There's no multifocality that needs to be induced, it is worth its weight in gold. Certainly for the older patients who are less mobile, and I'm now talking, a bit older, in their 70s and 80s, we have no issue with using multifocal lenses. You probably find these people aren't driving as much at night. They have a bit more tolerance to their overall vision based on the amount of activity that they do. But certainly taking a younger patient who's an avid golfer, for example, and they want to read the scorecard, they want to address the ball when they tee off and see where it goes in the distance. Usually with me, it's off to one side. That's not from my vision. Keeping the quality of vision along with giving them the range of vision is our big mandate.
Now, Prof. Alió, you mentioned about neuroadaptation, and often after we give someone a new vision experience, such as trifocality, you're waiting for them to neuroadapt, you're seeing them in the clinic and you're trying to be positive. For me, I ask all of my staff to push the plus, not in terms of a refractive outcome, but in terms of everything. I want them to be a positive experience. I want to emphasize they're not wearing their glasses. I don't want to focus on the downsides like the halos or the glare. I want to sort of push the positives. How do you help them through that neuroadaptation stage?
Neuroadaptation is a syndrome that is characterized by the feeling of poor quality of vision with associated usually dysphotopsias and deep unsatisfaction in terms of daily life activities. It might include a decrease in best-corrected vision for far and near. So neuroadaptation is really something that makes your vision to be bad, and this is something that we explore with difficulty, but the patient refers to us. The first reason for neuroadaptation failure is refraction. If you have a residual astigmatism or you have residual ametropia, you have to prescribe glasses to the patient to wait for a couple of weeks or 1 month to know if the patient is happy with the glasses, not happy with wearing glasses, obviously, but the symptoms disappear is because you have a problem with the refraction, and then corneal refractive story should follow. And if even with that, the patients are unhappy, it's because you are truly dealing with a neuroadaptation problem. Beyond the 6 months, and believe me, at this very moment, beyond the 3rd month, I prefer to IOL exchange based on my own results. So it's been a really interesting thing to see how to change the optical profile of the lens, being multifocal. Really, you get in a different neuroadaptation process. This was suspected by some MRI studies that demonstrate that different areas of the brain are activated by different type of multifocality. But it's true, in the real basis, the first case I had was the wife of a friend, obviously a recommended friend, that had a neuroadaptation with a lens, a multifocal refractive. After 3 years being unhappy, I finally decided to try to substitute and to avoid the problems of having a monofocal lens. Obviously, the patient was the wife of a friend, so very tricky case. And I was lucky because I always use a CTR, causal attention ring, in my multifocal patients, listen to everyone. The first reason is because it improves centration, but the second, if you have this not that frequent case in which you have to substitute the lens, then you have a good chance, even 1, 2, or even 3 years like this case with the multifocal. I did this refractive lens multifocal change by a diffractive, and this was the first case in which I had the evidence that this exchange happened to be work. The patient was happy. I was truly happy because I had confidence with her. And finally, this was the first case. Following this, I have done a kind of 30 cases. Success rate is 82%, is in the paper we're for publication. Definitely, we have to think that we have to face neuroadaptation in a positive way. First, to give a refractive solution in case that this is the factor that influences neuroadaptation. Second, if necessary, to decide a lens exchange if possible before the 6 months period that usually is left for the purpose, because at 6 months you really have a fibrotic capsule. But most of the surgeons don't use CTR, and you are going to be in trouble explanting a lens with 6 months or more. I use CTR, and even with CTR, I try not to be more than 6 months, and even at the 3rd month, if the patient doesn't show a trend to be better, you are going to have an unsatisfied patient, and then better to change the optic.
Thanks very much. That's tough operating on a family of friends. That's tough. That's awful. I wouldn't wish that on anyone.
Uh,
I promise.
Glenn, you had something to mention?
Yeah, so I mean, I agree totally with Prof. I mean, even from a presbyon perspective, just for example, a monovision perspective, that side of the equation where you're not having to deal with the dysphotopsia of the ring segments and the different multifocal foci, that any residual refractive error is sometimes the main instigator for the discomfort in the vision, the asthenopia symptoms. And you know, certainly from what we find is that just titrating a patient in the early post-op period, minimizing the amount of anisometropia, for example, or reducing any SIL, in particular any SIL that's oblique. When you find you have with the rule or against the rule SIL, it tends to be a bit more forgiving, but oblique SIL really, it plays havoc with both increased depth of field, spherical aberration profiles, as well as multifocal profiles. And the point is that you can tide the patients over with contact lenses, with glasses. We tend to wait much longer. We don't tend to enhance within the first 6 months. Also because the epithelium is still remodeling, certainly for the first 3 months in a myope and 6 months for a hyperope. Again, this is from a corneal procedure perspective. So we often see further change in patients becoming less symptomatic, both from the perspective that they're drifting into their true target, they're regressing into their true target from the initial overcorrection, and secondly, because they're adapting. Their brains are adapting. But we give them the helping hand, the pair of crutches when you've had your knee up. Your pair of crutches from the eye point of view is your interim glasses. And we encourage them to use them. We'll say, use them for driving at night where you're finding the vision a bit difficult. And most patients will come back to us at 6 months and say to us, yeah, I no longer need the glasses, they've fallen away. And for those few people that have finally stabilized and a little bit off target, and of course an enhancement will push them onto the target, and that's confirmed beforehand with a simulation.
Oh, that's a really good tip. I always try and stay away from glasses because, you know, I feel as though I've promised them that they're going to be glasses free. I think a lot of the statistics about glasses independence are probably a little bit exaggerated. I still feel like even my trifocal patients are probably wearing some glasses at night when they're reading.
Yes, agreed. I think most patients' frustration comes from the fact that they aren't able to, they can't do as much as they were doing before because of the reduction in vision in those certain areas. So by giving them those interim glasses, it keeps them productive. Yeah, it's not the ideal situation for them yet, but they'll get there in the end. Once we're finally able to enhance or exchange lenses, etc., it just ties them over and keeps them going.
Oh, that's a really good tip to keep a happy patient on the go, because that's the hardest part. Radhika, you had something to comment on this one?
Yes, I remember the name of the lady, Susan Marcos.
Good. And that's with the similar to the Vivior type assessor?
For MBBS, yeah. So the other thing to mention is that you're absolutely right. There's not enough data out there for how much spectacle independence or dependence there is. When I was collating the data for all lenses out there on the market in 2020, we really struggled. And who knows what, you know, they were commenting this on the data, but does that mean spectacle independence within 24 hours, within 6 months? This was not, you know, mentioned. Also talk about dysphotopsia. Is it a photic phenomenon or is it actually a dysphotopsia? And when we say dysphotopsia, are we meaning something that the patient is bothered by, or just something that is there but not bothering the patient in their visual activities? I think that's also something to kind of drill down on as we kind of refine our chat to the patient and also between ourselves.
I think one thing I've discussed with your co-investigator Damien before is that with trifocal lenses, I've had my most unhappy patients that have come out minus 0.5. And I think, wow, a monofocal patient, they would love that. Trifocal, they hate it. The happiest people seem to come out plus 0.5. And I still don't really understand why that is, to be perfectly honest. If anyone on the panel would like to say why, I'd be open to it, but I still haven't worked that one out. The other thing I'd like to ask about to do with patient counseling, which is probably the most important thing with all of you doing slightly unusual things that a standard cataract or refractive surgeon would maybe be uncomfortable with, is that we all aim for perfection. We're all aiming to get someone exactly what they want. And sometimes patients are unhappy. How do you approach the idea before your surgeries about counseling about the likelihood of IOL exchange, laser enhancement, rotation of toric lenses? Do you consent for all of that for every surgery? Radhika, maybe I'll start with you. If you're seeing someone in the hospital and you're thinking, oh, I might be trying something a little bit different here. We might be giving this person monovision or maybe trialing a different lens. How in depth do you go with your discussion about how you might fix problems if they occur?
I think it's extremely important one way or another to make sure that the patient not just signs a document, but really understands. I think when you're putting a toric in a patient, for example, I always clearly state that, a percentage of patients will require to, either they'll be fine because it's, the movement of the axis is within, 5 or 10 degrees and it won't really bother you too much. But you do have to mention that. And even within my NHS clinics, I still, even if I'm not offering the multifocal lens in the clinic, I always state mini monovision or a multifocal. Then I say, you could be offered this outside of the NHS and it's something that you should consider. But actually, in your case, with your background of XYZ retinal problems, it's probably not a good idea. So it's amazing because what you will see is that the odd patient will, and it'll just take 1 or 2 patients in your lifetime to come back and say, yes, you gave me this and I did not know about multifocals, or I did not know that I could have my astigmatism corrected. I think you have to have those conversations about clearing their astigmatism, giving them the multifocality range that they want, and also even with toricity, making sure that they understand what the pros and cons of doing that are. And also always doing a pentacam or an anti-segment OCT to look at, for example, the epithelium for early signs, changes in remodeling that could signify, form frust, or knowing if there is any sort of, baseline ectasia or other reasons. Not everything that blurs is an aberration.
That's a really good point. And this is maybe a slightly loaded question, but sometimes I get approached by new lens manufacturers who maybe make something that is monofocal plus, something a little bit different. And they'll say, look, you don't even have to tell the patient you're putting it in, there's no different, you don't have to tell them because it's very unlikely to have a problem, that sort of thing. I feel like, especially in those situations, you want to let a patient know. If you're using a toric lens, you'll talk about rotation. If you're using anything more than a monofocal, you discuss all of the side effects?
Yeah, absolutely. I think that's key. And you'll know from looking at a patient, sometimes they come loaded with questions. They've read your paper, they've read everything, and then they come to you. Or they'll come not knowing anything and not necessarily wanting to engage in all of that conversation, but you have to go past it, even if it's a fly past. You have to go past those bits of information. For sure.
And Glenn, when you're offering something a little bit different to a standard LASIK, like a Presbyon type treatment, do you mention that they may not like this? Do you mention that you might be changing the plan on the fly, or do you ever change the plan and make this their non-dominant eye, or make changes as you go? Is that something you consent for?
Well, firstly, I think the terminology informed consent says it all. The patient needs to know as much as they need to know. If you're going to take a flight to New York from London, you don't have to know how to fly the plane. You don't have to know how to do the surgery, but you need to know how to be a good passenger and need to know what to expect from the journey. So I think Yeah, I mean, we do extensive counseling. Patients, as part of their workup by our optometrist, first of all, will have a half an hour discussion in regards to all the potential risks, complications, side effects, but also to the expectation as to how they are expected to adapt after blended vision, for example. This is followed up with a bunch of paperwork, which they get to take home. They can read through and they can reflect back on that in the future. And then, of course, the surgeon reiterates that on a second day, second visit, in a more of a summary version, again, highlighting the adaptation process that patients will go through. From a presbyon point of view, it's not a magic treatment. 76% of patients will be fully adapted at 3 months. So that leaves about 25% still noticing the difference in their eyes in certain lighting conditions. They may be coping very well. They may not be having to wear interim glasses to reduce their anisometropia, but they're able to function, but it's not 100% comfortable at that point. By a year, that increases with neural adaptation and the eyes drifting further into target to around about 95, 96% across our myopic, emmetropic, and hyperopic patient groups. So, but the patient has to understand and buy into that journey. The long-term vision benefit that they're going to get for many years, because once you've adapted, you've adapted. You can increase the anisometropia later on if you need to as they get older. They're adapted. So it's really just making sure they understand that it is a journey, it's a healing end process. And this is very important when you're treating members of the same family or good friends. You treat
Yes.
the two people on the same day, husband and wife, and if one's a hyperope, they're going to have great reading on day one, but a bit fuzzy in the distance because of the intended initial overcorrection, which will regress. And the myope is going to have great distance and a little bit tricky on the reading. They can function, but it's not comfortable yet. They'll both meet in the middle when they get to that 3-month period when their eyes are fully settled in. So yes, making sure their expectations over the initial healing period is vital. Yeah.
Thanks. And Prof. Alió, I'd like to ask you something slightly different, and that is, you do a lot of laser correction, but also you use a wide variety of IOLs. If you do have a problem after surgery, maybe a small refractive error, do you have a preference for going back into the eye, or would you prefer to do something on the cornea if both options are viable?
That depends, Ben, a lot on the magnitude of the problem. If you have a refractive surprise with a +3, definitely it's better to go to the lens and to make a piggyback. I would do in these cases piggyback. You have a small astigmatism or moderate astigmatism, for instance, one diopter that you have induced because of the surgery or unlucky case, or you have some residual ametropia. The best option is LASIK. Always, we made a study and it's published 5 years ago, in which we compare the touch-ups with a piggyback, with IOL exchange, and with LASIK. It definitely was far better to use cornea surgery because you have much more precision, you have less chance to induce residual astigmatism, and finally, it's less aggressive, so you should have less complications. My preference is PRK. Let me tell you that this small difference in these people that are not that young is PRK, usually PRK, which is not that painful in these cases. And definitely you run out from the risk of the dry eye, which is far less in PRK, and everything that is related to the flap problem. So I prefer definitely PRK. I told it is signed in the informed consent and is offered as a free alternative in case that we have residual ametropia. So basis know that this can happen, and it happens, which means in this very moment, about 3% of our patients multifocals require a touch-up with cornea surgery. They know that it's going to happen, and they know that it's going to be by PRK because it's our experience and it's the best option for them. Having said that, it's not optimal, because PRK needs more than 1 month of recovery, 3 months because epithelial recovery is suboptimal, but it's cost-effective, and the patients are already alerted. I prefer the run less risk of ocular surface problems and flap-related complications than to have a slightly delayed recovery, because most of these cases are not a big deal. They're not high ametropias, and then the recovery of the epithelium, usually 1 month, you are able to end the process and to discharge the patient.
Yeah, I agree with you. I do a lot of transepithelial PRK. I think it's not as painful as it used to be. And I also agree that, our formulas are so good. We're not having such big errors anymore. They're often small things to correct. Well, thanks everyone very much. Managing unhappy patients is an unfortunate part of our job. Fortunately, however, there are many strategies and best practices in patient counselling that can help us to recover and turn a negative situation for patients into a positive one. On behalf of Jorge Alió, Glenn Carp, Radhika Rampat, and myself, Ben LaHood, I want to thank you all for joining us today. We all hope you learned something useful that you can implement the next time you're faced with an unhappy patient. Thank you very much. Talk to you again soon.